Will psychedelics become cost-saving public health tools or boutique therapies locked behind a paywall for the financial elite? I'm Elena, and this is the integration session where we explore the science, stories, and future of psychedelics. In this episode, we're going to explore the crucial economic landscape of psychedelic therapies with Dr. Elliot Marseille, a health economist and founding director of the Collaborative for the Economics of Psychedelics at UC Berkeley and UC San Francisco. As a leading expert and the author of several recent publications on the economics of psychedelics, we discuss innovative study design approaches that could enhance affordability and feasibility of these therapies, the economic viability of psilocybin for treatment-resistant depression in the US, emerging therapies with strong economic promise, and the crucial needs for future research and policy. Let's dive in. Hello, and welcome to the Integration Session podcast, Elliot. Thank you so much for being here today.
Thank you, Elena. I'm glad to be here and have a chance to share a little bit about the economics of psychedelics.
Yes, I'm very excited. It's a long-awaited topic, I think, for the podcast. So let's get right into it. The cost and feasibility of psychedelic therapies is often a major criticism of their sort of future implementation in routine clinical care. So, how did you become interested in this sort of problem and the economics of psychedelic therapies?
Yeah, well, most of my career has been dedicated to the economics of global health interventions, and mainly HIV/AIDS over really decades since I got my doctoral degree around 1994. HIV/AIDS has been my focus, and the underlying concern is there's not enough resources. There are insufficient resources to provide everything that would be useful to people and would be beneficial for their health. That's why economics is sometimes referred to as the dismal science. It's based on the premise that there's not enough to go around. So if you accept that, and I think it's hard to argue against it, you're then left with the question, how do you do the best with what you've got? So the work that I've been focused on, which really centers on cost effectiveness analysis, is designed to answer that question. How can you get the most health benefit with the available dollars? And with HIV/AIDS, it was particularly pointed in a way because we were focused on sub-Saharan Africa and South Asia and other resource-poor settings where a dollar really matters. It really matters how you allocate the funds. It's a matter really of life and death. But the principle is the same. You want to do the most good with what you've got. And so when I sort of transitioned from global health interventions to psychedelic therapies and wanting to understand the economics of psychedelic therapies, I brought the same mindset and really the same kind of conceptual apparatus and the same techniques that I had been working with for many years in global health and brought them to bear on psychedelic therapy. So as you say, they tend to be fairly costly upfront. A lot of therapist time, multiple sessions. So compared with SSRIs, there's a large upfront cost as opposed to a relatively small ongoing cost. And so then the question becomes, how can you justify that large upfront cost in terms of the extra benefit that you get from psychedelics? And the answer in many cases seems to be yes, that the upfront cost is in fact justified, and that payers can expect to get good value for the money, and they might even save money over time. So so there's no reason why a very clinician-intensive, relatively expensive one-time therapy, when I say one time, it could be 3 sessions, but it's a discrete package there's no reason why that couldn't be good value for the money. Did that begin to answer your question? I'm sorry, it was kind of a
Yeah.
long answer
No,
there.
yeah, definitely. I think you're getting right into sort of the economics of it. So basically, all of these mental health conditions have their own cost on the healthcare system. We often talk about like the economic burden of depression. So what you're saying is that psychedelic therapies, even though they might be more costly up front, they can actually have a net saving effect because it's reducing the burden of these mental health conditions.
Yeah, you got it.
Yeah.
It's really, yeah, it's nothing esoteric about it.
Yeah.
It's really quite straightforward. And the price really matters. In other words, even if it's, very cost effective or even cost saving, the cost matters in terms of how many people will be able to access these therapies over time. And I'm really concerned with that question. I think lots of people who are, interested in the potential benefits of psychedelic therapies are really concerned with access. And it's particularly uh, thorny with psychedelic therapies because of the residual stigma. And we don't have reimbursement models yet. Oh, and by the way, the FDA hasn't approved any of them yet. Oh, and by the way, they're still illegal, right? So there's kind of this current that we're swimming against, if you will. That's maybe not a great metaphor, but anyway, there are these issues that we need to address and be able to resolve. And having all else equal, again, I'm not saying anything, radical or even very interesting, but all else equal, if the cost of the therapy is lower, it'll be easier for payers to pick it up and make it available, at scale.
Definitely. And why is considering the economics of these new interventions, considering it is so new? I mean, like you said, there's not even regulatory approval for many of these therapies yet. And many have only done pilot trials, very small pilot trials with few people. So why is it important to consider the economics at this stage?
Oh, it's never too early. So, uh, well, actually, that's not quite true. But the way I look at it is, as soon as there's a significant signal of real efficacy, like usually at the phase 2 trial level, it makes sense to start at least penciling out the cost effectiveness, and starting to lay the groundwork for acceptance by payers who, cost effectiveness is not the only thing they look at, but it's very important. And of course, they do look at cost and cost effectiveness. So I sort of am a believer in getting the word out early and allowing payers and other policymakers to start getting adjusted to the fact that there are these new interventions on the horizon, many of which will be very good value for the money. Yeah.
Okay. Yeah, and getting into some of your papers, because you've had quite a few really great papers come out recently. And in one of them, you critique the Lycos funded trial on MDMA therapy for PTSD. And I think in your paper, you argue that the choice of the placebo comparator would be sort of inappropriate for real world decision making. So why are you comparing psychedelic therapies to standard of care treatments in the real world, and why is that so important from an economics viewpoint?
Yeah. So payers don't pay for placebo. They pay for actual treatments in the real world.
Hmm.
So I was a little puzzled by that paper. These are very competent analysts, but I was a little I couldn't quite understand why they chose placebo as a comparator, because it's just, I mean, it's sort of interesting to know that an intervention is cost effective compared with placebo, but really what's far more relevant is cost effectiveness compared with other feasible standard of care interventions that are actually being offered. That seems to me the relevant policy question.
Hmm.
And cost effectiveness analyses, in my view, should be structured so that they answer real world questions that can shift the way resources are allocated, and specifically, whether payers would adopt them. So that was my criticism of that particular
Yeah,
paper.
definitely. And you also point out that 3 MDMA doses might threaten accessibility. So, what kind of alternative modeling do you propose that would make the price more reasonable? And how could that make MDMA therapy not just cost effective, but like cost saving, like you mentioned earlier?
Yeah. Well, there are different pricing models, and there's some innovative ideas that could be implemented here, such as value-based reimbursement. And there are real-world examples of this. This is not just a theoretical construct. Um, Novartis did this with a leukemia treatment, and was it Merck? Uh, that did it with a Novartis did it with a diabetes treatment, and I believe it was Merck that did it with a leukemia treatment. In any case, the point is that withhold, payers pay the full amount upon proof of durable benefit. And there's variations on this. They could pay a base rate going in and then pay additional money upon certain benchmarks, certain clinical benchmarks being met, such as remission lasting for a period of X months or something like that. Um, and I mean, that's one model. Um, and if we as a society say that we are determined to make an effective new treatment for example, MDMA for PTSD available at scale, um, I'm happy for my taxpayer dollars to help subsidize that. There's really a case to be made for there being a societal benefit, and to conceive this narrowly in terms of payers is to leave a lot of potential benefit on the table. So, for example, one of the things we know is that people suffering from PTSD have high rates of absenteeism, and their efficiency at work is less, so their productivity is less. And it turns out that the potential increases in productivity, the dollar value of that productivity, can be higher than the healthcare savings when when their symptoms remit. Um, so as a society, we benefit from that productivity. So there's a larger way of holding this, which sort of makes the case for sharing the costs more broadly. Um, so so it doesn't need to be. We don't need to be stuck with a model of profit maximizing or revenue maximizing as being the thing that we're organizing the prices around.
Hmm. Yeah, that's such a good point. And what's your advice for researchers that are doing psychedelic studies? Like, what are meaningful, like, health economics outcomes that they could be including?
Um, Meaning, would you run that question by me again?
Yeah, yeah.
What?
So in psychedelic research, whether it's like a pilot study, you mentioned earlier that it's never too early to be considering the economics of these interventions. So what kinds of things can researchers include in their studies to assess the cost effectiveness of their intervention?
Yeah. So stop me if this isn't exactly what you're asking. Okay. So I don't
Okay.
I don't want to get yeah I don't want to go someplace that's less that's not to your point. But so the way cost effectiveness analysis is done is you cost the intervention. What does it cost to deliver it, taking everything really that's relevant into account. And then, as we were talking about earlier, you subtract from that the future savings that might accrue from that. And then you compare that with the health benefits you get. So people who are doing cost effectiveness research in psychedelics, really, it's not conceptually different from cost effectiveness analysis in anything else. A cancer treatment or cardiovascular treatment. You're weighing costs. You're weighing net costs minus savings over time, and comparing that with benefit. And we have various techniques for quantifying health benefit that takes both extra years of life into account and the quality of those life years into account.
Hmm.
So, was that what you were
Yeah,
asking?
yeah. I was
Yeah.
thinking about quality adjusted life years. So you
Oh,
sort of
well, yes, I
explained
was
that.
trying to stay away from the dreaded quality word, but yes, that is what I'm talking about. Right. You
Okay.
combine extra years of life and you adjust that by the quality of that life. And
Okay.
by the quality of that life, I mean, most of us would agree that they would prefer to go through life having sight in two eyes rather than in one eye, for example. And so we have a way of adjusting the quality of life according to these various symptoms and disorders that could decrease the quality of life.
Yeah. And transitioning to another paper that you published, you did sort of an economic analysis of MDMA assisted group therapy for PTSD, specifically in the context of Russia's invasion of Ukraine. So, what are sort of the headlines from that study? What are the economic benefits of that model that you proposed?
Yeah. So two things here. One is the particular situation in Ukraine, and I want to talk about that.
Hmm.
But also the point you made about group therapy for in psychedelic therapy. So um, everybody agrees, almost everybody agrees, I think, that we need to transition away from the very clinician intensive model that MAPS originally developed, where you have two clinicians and one client for all the sessions, for the introductory sessions, the dosing sessions, and the integration sessions. It's really expensive to do that. It's a lot of clinician time. And not only is it expensive in dollars, we don't have enough trained clinicians to deliver at scale once FDA approval is realized. And so we've got to find a way to amplify the reach of the clinicians who are trained. So for both those reasons, group therapy can reduce the cost per person who receives the therapy. I think that's straightforward. You're treating more people per clinician. And then the other part of that is that you're preserving or extending the reach of whatever the clinician pool you have is. Is that a sentence in the English language? Yeah. So that's actually, when I was doing this analysis, I wasn't really thinking that much about the effects on the clinician pool, but realized at one point, actually, that may be the most important part of group therapy, because in the United States, that's going to be a big bottleneck, is the number of clinicians who are trained and available to do this. Also, we don't want to be pulling clinicians away from other behavioral and mental health treatments, conventional ones, which are already under funded. There are long waiting lists for people who need help. We want to pull as few people away from those treatments and into psychedelic treatments as possible. The right number to pull away would be zero. So, really, really need to value clinicians and extend their reach as far as possible. So, in Ukraine, so work has been done in the United States of testing these models, and they seem to work very well. I mean, there's a point where the group can be too big. There are limits to it, but you can get substantial reductions in cost. In Ukraine, because of the scale of the trauma, which is growing day by day, there's no way that individual therapy is going to have a public health impact. And so the Ukrainians are very interested in a group models. And so the study that you referenced, um, so the government has not approved MDMA to treat PTSD. There's a movement afoot to get it rescheduled and to have the legislation and regulatory approval to do this, but it's not a done deal by any means. MAPS has trained 60 Ukrainian clinicians in delivering MDMA-assisted therapy for PTSD. And there's a growing community of therapists in Ukraine who see the value of this and are working to make the reforms. And so I wanted to show, or I wanted to see whether, as in the United States, it would be cost effective or cost savings in Ukraine. So I set up a way to calculate what it's likely to be in Ukraine. We don't know, we don't have empirical information yet. And it looks extremely good, like very likely that it's, very unlikely that it's merely cost effective, almost certainly cost saving, particularly if you take productivity and caregiver costs into account. So these broader societal benefits. So it looks very good for Ukraine. And so, I'm hoping that the work we did helps to persuade policymakers in Ukraine to start thinking about this and planning for it.
Yeah, I think I have here in my notes that the paper mentioned 48,000 lives could be saved and 5.6 billion in societal savings, which is
Yeah,
pretty incredible.
yeah, no, it's real public health impact and it's real money.
Yeah,
Um, yeah,
yeah.
yeah,
And
yeah.
you also touched on caregiver costs. So how do those sort of factors amplify the economic case for psychedelic therapies in places like Ukraine?
Yeah, so and this isn't confined to Ukraine. It's really anywhere where people are suffering from severe PTSD. Sometimes family members can't work and have to take care of those people, or have to work less, or they have to hire help for people who are like severely disabled by PTSD or depression. So it's one of the societal benefits that you get as people's symptoms improve and they can return to having some kind of quality of life. So yeah, so that's another one of the benefits. I mean, there are other things that we haven't quantified. So we know, for example, that people with PTSD have higher incidence of getting into trouble with the law, domestic violence, these kinds of issues. And I don't know how to quantify that yet. And it's definitely quantifiable. I've been talking for a long time about wanting to do that. I haven't done it yet. So anyway, but there are these other second order effects that are worth thinking about and ultimately accounting for.
Yeah, that's so interesting because the impact of mental health issues like PTSD, they do ripple out in so many different directions. I'm thinking like maybe it's harder to be a good friend or a family member or a Samaritan, or maybe there's environmental impacts so it's hard to account for all of those. But yeah, very interesting work.
Yeah.
And yeah, looking towards treatment-resistant depression and psilocybin therapy in the US specifically, because I think this is one psychedelic intervention that has the strongest evidence. So, can you walk me through your recent paper again on this topic and the main results? So, why psilocybin therapy might be a cost-effective option, and how sensitive are the results to pricing?
Yeah. So I was one of the authors on this paper, but I was not the lead author. The
Okay.
lead was Anton Avicenna, who's
Okay.
a terrific health economist at the University of Texas. So he did the main modeling. He did the heavy lifting on
hmm
this. Um, but so the idea was to look at efficacy data from Godwin's publication um, on psilocybin for TRD. So that's what we used for efficacy. And then we costed out what it would cost to deliver the psilocybin therapy. And we used our base case estimate was so $5,000 all in for the therapy, for the clinician and the cost of the psilocybin itself. Um, it Psilocybin for treatment-resistant depression is not as dramatically efficacious as MDMA is for PTSD. And so how cost-effective or cost-saving it is very sensitive to the overall cost of the therapy.
Mm.
Uh, and so let's see. Actually, I have a note on this because I knew you were going to ask me. I just want to have the numbers right.
Definitely.
Um, yeah. If the if there's if the therapy costs $10,000, there's about a 1% chance of it being cost effective, and that increases to 95% likelihood that it's cost effective if the total cost were $3,000.
Mm.
Uh, and so a lot hinges on the cost of the psilocybin itself. But I think there's reason to believe that it could be around $500 or $1,000 or so in that range. In which case, the psilocybin would be very good value for the money. The other thing I should say is it's maybe a little conservative, that is, negative, or the way we presented the results might be a little bit pessimistic in the sense that we assumed benefits wouldn't extend beyond 1 year, and we don't know if they could extend beyond a year. Obviously, that would make it more favorable. And so now I'm making sort of a general comment about where the field is. We really need longer term outcome studies, really for all of the psychedelic therapies that are coming forward. It's really expensive to do clinical trials, and it's really expensive to follow people up over time. I get it. And yet that information is really, really vital to understand the value.
Yeah, so that's a good tip, I guess, for researchers that are designing studies is to include longer follow-up so you can determine are these effects durable and then make your predictions for the economics of the intervention based on that. Is that what you're saying?
Yes, that's
Yeah.
right.
Okay,
Yeah.
yeah, it's a good point. So, yeah, you mentioned the future and what needs to be done. So, what emerging psychedelic therapies, from your perspective, are showing the most economic promise beyond just
Well,
MDMA and psilocybin?
yeah, yeah. So there's really good evidence that psychedelics for addictions of various kinds are particularly effective. And I'm not going to speculate why that is because I'm not a neuroscientist or a clinician. But I think there's pretty widespread agreement that this is where we're likely to see very good effectiveness and also good cost effectiveness. So psilocybin for tobacco cessation. Matthew Johnson has done some really, really promising work, and we're working on a cost. We have a cost effectiveness model for psilocybin for tobacco, and we hope to submit it for too much longer.
Hmm.
Psilocybin for alcohol use disorder, also extremely, extremely promising. And then the other one that's getting increasing attention is ibogaine for opioid use disorder. Very, very good evidence of the efficacy of ibogaine for getting people through the initial withdrawal syndrome. So that's huge. And you've got to get through that if you're going to be abstinent long term. And we don't yet have clinical trials on the long term benefits of ibogaine therapy for sustained abstinence. And there's a move now, the American for ibogaine, there's a large 15-state initiative to direct some of the money from the Sackler settlement funds to do those trials for ibogaine for again for long-term abstinence from opioid use disorder. Hugely, hugely important, given the fentanyl crisis and the opioid use problem in this country.
Mhm. And yeah, another thing that sort of came to mind when you were speaking there is I think we've been mostly referring to high dose psychedelic studies, but have you thought a bit about the economics of microdosing psychedelics and how that might compare?
Yeah, so I'm probably going to annoy a lot of people who swear by microdosing. And so a couple of things. First of all, it's not something I follow very closely.
Okay.
And there may be, so I want to put some caveats in here. I'm going to get into trouble. There may be some controlled trials that have been done recently that suggest benefit. Um, but my overall sense is that there's not as much benefit as people, how to put, here's how I put it. If people feel better after microdosing, I am not arguing with that. That's great and it's genuine. They really do feel whatever they feel. However, it's not clear that there's any particular benefit beyond what they would get if they thought they were getting a psychedelic but weren't, i.e., if they were getting a placebo. So I am totally open to evidence that microdosing has real clinical or other benefits. And I'd be really interested in valuing it. But in the meantime, my plate is more than full with macrodose therapies where it's really clear that people are getting benefit.
Mhm. Yeah, that's fair enough. And we're at the last question now, so I would just love to know what you're working on next. You mentioned a tobacco analysis, but what else do you have planned?
Yeah, so I want to share about um, some work I'm doing now that's not exactly economics of psychedelics, um, but um, but has implications for psychedelic therapies for sure. So um, here's what here's what kind of triggered my thinking about this. In 2021, I think I have the year right. Robin Carhart Harris was the senior author on this New England Journal of Medicine paper that compared psilocybin with escitalopram, people with depression. And they had three standard outcome measures for depression, and they chose one as their primary one. In addition, they had something like 8 measures of well-being, job satisfaction, quality of relationships, flourishing, like that, a bunch of them that measure different aspects of well-being, including extending into what you might call positive well-being states that are beyond the mere absence of symptoms. The primary outcome measure that they chose was, in a way, was a bad roll of the dice because there was no statistically significant separation between the psilocybin group and the escitalopram on that primary outcome measure. There was statistically significant difference on the other two standard symptom-based measures of depression, which they had included as secondary outcomes. But really, and here's where I'm getting to the point I want to make, on all of the well-being scales, there was statistically significant superiority in the psilocybin group. And lots of trials have as secondary measures, one or more, usually like a battery of well-being measures. And psychedelics tend to do really well on those measures, but they're secondary outcomes. So it's kind of part of the atmospherics of the result. They're in the discussion section and people are, oh, well, that's interesting, but it doesn't move policy, and it doesn't move the FDA as much as it could because it's not a primary outcome. You can't post hoc say, well, these are the outcomes we really care about, right? Of course, yeah. So my argument is that a lot of benefit is being left on the table in the evaluation of psychedelic therapies. We're not valuing these well-being outcomes because we have this kind of, especially in cost effectiveness analysis, it's really limited. We don't look beyond the mere absence of symptoms. We call this utility. 0 is you're dead. 1.0 is you don't have any symptoms. But we don't value positive health states beyond that. Things like, access to joy, connection with nature, satisfaction in your relationships or your job. So what I want to argue for is that clinical trialists have more than one primary outcome. It turns out the FDA is happy to look at more than one primary. You can declare more than one. So I'm not arguing that we get rid of the symptom-based outcome measures. That's fine, they're important, like 100%, but also have these positive well-being measures. And one of the problems is that there's so many of them and there's no agreement about which one is the best. And so I'm proposing that the experts do a Delphi process and use appropriate statistical techniques to construct a positive well-being, a well-being measure that includes positive well-being states that can achieve consensus and that the FDA would look at. And Elena, it's one of these things, it's like you've heard this, it's a cliche almost, but you get more of what you measure. And so if we're sending a signal to the ecology of pharmaceutical development and clinical trial and FDA application and FDA review, we send a signal that we value well-being itself as distinct from the mere, I don't want to say mere, but as distinct from the amelioration of symptoms. We're going to get more interventions that enhance human well-being. So I'm excited about this, and I've got a great team. Robin Carhart Harris is a co-author on this. I'm just, of course, delighted to have his support and others. So we're working hard on this and hope to submit it before too long.
That's incredible. That sounds like an amazing project that you guys are working on, and it'll be so impactful, I think, especially in relation to psychedelics, like you said at the beginning, because maybe these are treatments that could help achieve that, not just the absence of symptoms, but well-being and living good lives and all of the societal and economic benefits that come along with that.
Yeah. Yeah, there's one more point I want to make about it is
Sure.
um, psychedelic interventions really are a great example of where well-being improvements are not being sufficiently valued. But this is not about psychedelics. In other words, this isn't like special pleading for psychedelics, like psychedelics are different and you need to measure outcomes in a different way. Not at all. This could be any psychiatric intervention and non-psychiatric interventions. This is the field is moving in this direction anyway, in terms of valuing patient-reported outcomes. So, this is just kind of riding the horse in the direction it's going. We'll get there, and I think it'll make a big difference.
I think so too. Thank you so much for joining me today, Elliot. This was truly a pleasure, and I really appreciate your knowledge.
The pleasure was mine, Elena. Thank you. All right. Bye-bye.
Thank you so much for listening to this conversation with Dr. Elliot Marseille, and thank you to the Center for Psychedelics Health and Research at Queen's University and the support of the Ontario Brain Institute, the Canadian Biomarker Network in Depression, and Providence Care Hospital. Until next time, be well and integrate wisely.